We're back after break with the topic robot-assisted MRI guided prostate biopsy. So, Dr. Ciuvasovas, radiologist, Republic Lipid Hospital, please share with your experience.
Thank you very much. Good afternoon to everybody. I will talk about robot-assisted MRI guided prostate biopsy, and I have no financial disclosure, unfortunately. And I will start with case number one. Patient 66 years old, PSA variability now 8.2. It was 4 sessions of systemic biopsy. It was negative for prostate cancer. What to do? Of course, nowadays it's not question. Patient sent to MRI, and MRI findings, we can see big anterior part lesion, PIRATS 4, maybe even PIRATS 5, bilateral. And what to do in this case? Of course, biopsy. Biopsy result, 3 samples, and one of them Gleason 7, 30%, 2 months follow-up radical prostatectomy. It upgrade to Gleason 3 plus 5, 8. Is subgrade for cancer. This case nice present its collaboration MRI together with targeted biopsy, how it worked together. MRI has become widely used in clinical practice about 10 years ago after introducing PIRAT system and this system update in 2015 and 2019. What does it mean? With MRI, PSA became visible. But what to do with findings, with these founded lesions? I answer this question with cases too. It would be 2 different patients, both with small PIRATS 4 lesion in peripheral zone, upper case in dorsal part, and next patient analogical small lesion in anterior horn of peripheral zone. It looks like similar. Patient looks like similar. 2 clinical situations. First patient, 60 years old, 5.28 PSA. It's half time ago biopsy with no prostate cancer. Next patient, 68 years old, PSA growing up to 9.4. Histology years ago. It was on both sides. One small 40 of Gleason 6 cancer. Is they the same? Could MRI answer which is significant cancer, which is maybe beneath 9 lesion? What to do next? Following guidance on prostate cancer, what we have recommendation? If MRI positive, it's recommended combined targeted and systemic biopsy for biopsy naive patient. If patient after negative biopsy, in case of positive MRI, perform targeted biopsy only. In the same guideline, we have discussion how do what better pathway. It's 2 ways. Strategy A with combined pathway. When in case of positive MRI, we do systemic biopsy plus targeted biopsy, or in case of negative MRI, only systemic biopsy. Negative MRI is PIRATS 1, 2. In strategy B, MRI pathway, in case of positive MRI, we do only targeted biopsy. In case of negative MRI, only active surveillance without biopsy. What is the same point of both ways? Targeted biopsy in case of positive MRI. In advantages of MRI pathway, we have some big clinical trials. They show advantages of MRI pathway strategy and MRI guided biopsy. They show that clinical detection of clinical significant cancer outperform systemic biopsy in the repeated biopsy setting. And how it's look in clinical cases. Next one, if we compare systemic biopsy and targeted biopsy. 56 years PSA rise to 9.4, 2 sessions of systemic biopsy. Last biopsy was the same month before MRI. Both sessions without prostate cancer. In MRI images, we can see a huge anterior lesion. Biopsied, it was both samples Gleason 4+3. I saw grade 3 cancer. Radical prostatectomy. After a couple of months, it was the same aggressiveness cancers, 80% of prostate. I remember you, it was 2 sessions of negative TRAS biopsies. Unfortunately, prognosis and the follow-up of this patient was sad. It was cancer progression. How we can do targeted biopsies? For today, we have 3 ways how to do it. One of the simple ways is cognitive fusion biopsy. It's a standard TRAS biopsy guided by checked lesion on a prostate map. What is advantages of this type? We don't need special equipment. It's widely available. It's cheap. It can be combined systemic biopsy and targeted biopsy, and sufficient accuracy for enough big lesions in dorsal part. Disadvantages, of course, no lesion visualization. It's just if MRI and ultrasound image fusion is due in urologist mind, and of course it's low accuracy for small and anterior part lesion. Small lesion, we mean less than 1.5 centimeters. And of course it's harmful for urologist vision because you must looking at the same time ultrasound machine and do prostate map. For example, how looks like a lesion acceptable for cognitive fusion biopsy. Big Pirates 5 lesion, all lower part of prostate. In real case, it was unfortunately it was negative ultrasound guided biopsies. In histology targeted biopsy, it was 3+4 full samples. Next one. Excuse me, I missed one case. Next type of targeted biopsy is MRI ultrasound fusion biopsy. When previous scanned MRI images fused with real-time ultrasound images on special device with dedicated software. Advantages of this type is possibility to see lesion. It's not really see, but see with images, with MRI images scanned before. It's possibility transrectal and transperineal approach, what's very important. It can be combined systemic biopsy and targeted biopsy, and sufficient accuracy for much less lesions. Disadvantages is very expensive special equipment. It's no lesion visualization in real time. It's enough long procedure time, and in many cases general anesthesia needed. For example, lesion suitable for fusion biopsy, small Pirates 4 lesion in dorsal part. In real, it was the same after 2 negative systemic biopsies. Histology on targeted biopsy was Gleason 4+4. And third case, MRI guided biopsy in bore biopsy. Advantages of this type is lesion visualization in real time. It's transrectal and transperineal approach. It's lower basic equipment price compared to fusion biopsy. It's similar accessibility to all prostate parts. It's not very difficult or easy parts. It's the same. No sedation need. One of the best accuracy. Of course, disadvantages it have too. We need special equipment. It's enough long procedure time, and most important for this time, it's impossible for systemic biopsy. For example, case. We go back to our cases, what we see, case number 2. 2 patients with small Pirates 4 lesions, and it's the difference. We know which modality is most suitable now. What is what? Which is aggressive lesion, which is not. First patient was biopsied, 3 samples, 2 of them focal chronic prostatitis, 1 benign tissue. It was benign benign process in lesion. Next lesion, small, it's less than 4 millimeters lesion. It was biopsied with MRI compatible needle, and we can see its checked position during procedure. Both samples, Gleason 4 plus 4 is sub-4 cancer process. Of course, it's aggressive cancer, which you can see it's the same appearance on MRI, but absolutely different clinical result. In our hospital, we start MRI guided biopsy science 2019. Our hospital was first center in East Baltic region working with robotic assisted biopsy system from Soteria Medical. And biopsy system consists of robotic arm operated by compressed air and fully compatible with 3 Tesla MR field card with compressor and control PC. And all system is connected with 7 meters length high pressure air tube. I was looking with all is connected. Robotic arm is powered by compressed air. This arm is manipulated from control room remotely. You can see robotic arm is connected with needle guide. Needle guide position is checked by fast T2 sequences. We can see basic anatomy and needle guide position, and it corrected how we need remotely from control room. When position is right, we perform high resolution T2 and DVI sequences for lesion position and planning our samples place. When this job is done, we taking the samples. In case if we use MRI compatible needle, we can do next scan for needle position or for checking needle position. You can see in this slide how calculated needle position correlates with real needle position. Our tools used during procedure. In upper row you can see needle guides. New one in left side is thinner, and what's important to us is filled with water, and the older one is the special gel. And we use 2 types of needle. In upper row you see a semi-automatic Titanic MRI compatible needle, and lower it's a standard biopsy needle. What is different? Of course, MRI compatible needle is about 10 times more expensive, and samples with semi-automatic needles is not so good like automatic. But of course, advantages, we can always check a needle position during sample taking. It's very possible, and we use it for very small lesion, very anterior part lesion. So it can help be absolutely sure we take samples from places we would like. I would like to show you short video from our center in Klaipėda. Our 3 Tesla MRI. Robotic arm is calibrated before procedure. Patient without anesthesia, without sedation, is preparing for biopsy. We checked diagnostic MRI history. Needle guide is inserted, and the robotic arm connected with needle guide. And all system ready. We plan it and change it if need needle guide position. When position is correct, we can take samples. So it's very short how it look like. Now for today we did MRI-guided biopsies for 347 patients. It's more detailed data from our first calculations. Yeah, and what I would like to show you, its average procedure duration was about 40 minutes. Now we have about half hour. Average samples per lesion. Now we are taking 3 at least, and positive samples. It was 63% cancer positive. Our last calculations show our all cancer detection rate more than 77% and clinical significant cancer close to 60%. It's not the same situation. The last 20, for example, last 20 patient, our cancer detection rate was 85% and clinical significant cancer much more, 76%. If we're looking more detail with PIRATES 4 and 5, it's logically PIRATES 5 is more detected clinical cancer detection rate. It's almost close to 100%, and of course 2/3 of them are clinical significant cancer. PIRATES 4 case it's much better, and it's about 20% no cancer detection on PIRATES 4. Learning curve, how changing our evaluation. You can see it was first cases, PIRATES 4, it was cancer detection rate, it was close to 60%, now it's more than 80%, and for PIRATES 5, it was 80% cancer detection, PIRATES 4, and 96 for clinical significant cancer. Compare our center with other literature data from Spain. 31st cases, Professor Villanova, overall detection rate 73%, clinical significant cancer detection rate 86%, but clinical significant cancer Gleason 7 or more, and maximal, or Gleason 6 and maximal cancer core length more than 3 millimeters. Next center in Netherlands, it was overall cancer detection rate 58% and clinical significant cancer detection rate up to 44%. It means that clinical significant cancer Gleason 7 and more. And in our center, its overall detection rate 77% summary and detection rate 58%. But what is problem? All different clinical significant cancer definitions. It's a problem, but it's for next presentation maybe. What's important talking about biopsies? Crucial points before doing biopsy. Of course, it's at first accurate primary MRI evaluation. How it's important, I would like with cases. One case, you can see MRI images, patient 70 years old, PSA 2.2 with finasteride, biopsy naive, MRI PIRATES 5 lesion in anterior transition zone, huge lesion, same in T2 and in ADC and high B-value images, typical cancer appearance. We do targeted biopsy result, all 3 sample fibromuscular stroma. Why result that is negative? You can see it's not cancer. Why result is negative? If looking cancer just in transversal, in axial planes, if we're looking sagittal or coronal images, we can see it's not a real lesion, it's just thickening of surgical capsule. Our experience with PIRATES 3 lesion and PIRATES 2 lesion is almost negative. In all 17 cases biopsy, it was only 1 Gleason 3+3. Of course, we don't do PIRATES 2 at first, but it reclassified retrospectively from PIRATES 3-4. They are coming from other institution like with PIRATES 3 or 4, but during procedures it's changed to 4. But of course, it was due at our first stages. We are starting with these procedures and we do this biopsies, but result is doubtful. It's not a good point to do this biopsies. Correct patient selection. it's important. Patient must be PIRATS 4-5 or real PIRATS 3 cases with risk factors. It must be operator must evaluate the diagnostic MRI before procedure itself. Diagnostic MRI must be no older than 6 months old, because in this time it can be many changes in prostate and you don't see sometimes lesion. Not all lesions need MRI guided biopsy. What is example? A huge lesion, for example, huge lesion in lower part of prostate. It's huge PIRATS 5 lesion in dorsal part of prostate. It's, of course, these cases are possible by with cognitive fusion, what is more cheaper and simple and more faster to do. What is benefits for radiologists? MRI guided biopsies. At first, it's one of the best feedback for MRI evaluation. You know what is in lesion is. We are going from subjective visual evaluation to objective histologic verification. Of course, be honest, it's not objective too, but it's a gold standard. And it's increased value of radiologists in MDT. What is benefits for urologists? At first, it's additional high accuracy tool for prostate cancer diagnostic. It's a problem-solving procedure for complicated clinical case, what you can see in our examples. It's confidence in diagnosis after MRI findings. Of course, it's less repeated biopsy. Patient will be happy. Whole message to you: MRI guided biopsy is most accurate targeted biopsy, but limited availability. It's could be a problem-solving procedure for complicated clinical cases, and MRI guided biopsy results depend on biopsy technique as well as on quality of primary MRI evaluation and correct patient selection. And Michelangelo painting, radiologists give a helping hand to urologists. Thank you. I'm ready for your questions. Sorry, but
Thank you for your presentation. Is there any questions from the audience? I hear this. No? So I'd like to ask you a question about PIRATS-3 lesions. How often do you do? You showed some PIRATS-2, PIRATS-3, 6 lesions, yeah. But is this the only?
Rare, very rare. We do it's rare. I try. Don't do it. Of course, if it's real PIRATS-3 lesion with clinical suspicion for clinical significant cancer, of course we do it. But in many cases, coming PIRATS-3 lesion is not PIRATS-3. In most of them are PIRATS-2 lesion, not standard lesion. And I think in this case, follow-up is better tactics.
Okay, and how long did it take to you to be confident with MRI guided biopsy? You showed 64 cases.
Yes. We do calculation at first. We do it after 64, after 4 cases. I don't know. I now do 300 more cases, but I think I just learned. You always learn in medicine because it's very some result is very doubtful. Of course, what we talk, for example, Gleason 3+3 cancer. Formally, it's clinical insignificant cancer, but radiologists working with prostate MRI know. One case we have, for example, for after TRAS biopsy 3+3, you didn't see anything in prostate, anything. PIRATS-1 or PIRATS-2, you can anything. In other case, you have real black MRI appearance of significant cancer, and you get the same 3+3. So I think we have big hope to pathologists. Maybe they can say something different. That Gleason not talk is just even one criteria for aggressiveness. I think it's much more criteria and depend how it looks like on MRI, it's different. So I'm looking very clinical significant cancer in 2 cases, in of course gleason 7 and more, but size is important too. And in cases if coral length more than 6 millimeters, its lines correspond with volume of lesion. It means it's more than 0.5 millimeters. So it's we can think it's about significant cancer too.
So actually, if we see the cancer on MRI, so we should look for it. If we don't,
yes,
maybe we don't need to look for a cancer at all. Just when there is no clinical suspicion. Okay, thank you.
Thank you.
Thank you for the nice presentation.